Thanks, Rahul. I'd like to thank the association and everyone, especially Dr. Lopa Mehta and all the speakers before me who have paved the way for this lecture. And I will spend the next about half hour plus minus a few minutes talking about the history of history taking and diagnosis through the ages. But the focus, well, this is fitting that we start with the last slide. So I'm going to just get back on. Um, and it's kind of the focus today is really going to be more on history taking and patient interrogation and not physical examination. And in case that needs to be covered, Rahul, I think it would be a good idea at some point to do that separately because as I was running through the history of history taking, I realized that the two things, uh, patient interrogation, the medical interview, and then actually examining the patient, perhaps while done together, are two slightly separate entities. And I'm going to start with the case because the whole issue today, and I know that there are many students attending, as well as physicians in practice, is this problem that we face related to history taking. And nothing exemplifies that but this case of a 45-year-old man from a troubled African country who came to my clinic for a biopsy with a single sheet of paper mentioning that he had pleural extrapleural masses. He was asymptomatic. He had nothing else with him. What I was able to gather from his businessman friend, who was his translator, was that he'd been to Jordan and Shanghai where he had been biopsied. Both were negative. He'd been to Bangkok where he was advised a VATS biopsy and he got frightened, ran away to meet his businessman friend in India. So I did a CT scan because we had nothing to go with. And these were the lesions that were seen in the chest, and that those are on the sagittal and the coronal planes here. And my oculobrachial reflex struck in, and I said, maybe the Jordanians couldn't do anything, the Chinese couldn't do anything. He ran away from Thailand, but as an Indian, perhaps I can get the diagnosis. And so I went in, biopsied the lesion, and during the biopsy, I realized that the lesion was friable and hemorrhagic, and I kind of figured that I wasn't going to fare any better. I was writing out the case history and the probable diagnosis for the histopathologist because that's the system we have in place. And I kept looking at the scan and then I saw something and I looked at it. And after the biopsy, I figured out there was no spleen and that there was focal thinning of the diaphragm. And I went back and spoke to the patient, and he said, I had a gunshot injury 20 years ago. I had a surgery, my spleen was removed. He remembered all this, and the surgeon had told him that his spleen had shattered and his diaphragm had ruptured, and that was where the thinning was because this is where it had been sutured. And this was a case of thoracic splenosis, which luckily the biopsy confirmed. The side story here is that the pathologist called me quite concerned, saying, Bhavin, I'm seeing splenic tissue. Did you by mistake go through the spleen while entering the pleura? And, we had a couple of such medico-legal cases as well. And I said, no, you've just proven my point. But think about it. Across 4 countries, not one person, including me, had bothered to sit down with the patient and talk to him. What I did was post facto, and that doesn't really count. All of us saw the pleural extrapleural nodules. We saw a chance to biopsy and to get an answer, and that's what we jumped into. Whereas the diagnosis just lay in the past history, and if anyone had just bothered to talk to the patient, understand the situation, and then just put 2 and 2 together, I don't think the patient would have had to travel to India for the diagnosis, nor would the patient have needed 3 interventions and a 4th possible one to get to the answer. And so while there are lots of variations of this, what I have learned over the last 30 years in practice is that those who don't learn from history, and there's a double take on the word history, are doomed to make mistakes. So if you look at it, history taking, patient interrogation, the medical interview, whatever you call it, is the bedrock of modern medicine, the pathway to a correct diagnosis, and the initiator of appropriate management. Yet, for a variety of reasons today, and that is not the scope of today's presentation, this is ignored or poorly done by the majority of doctors across the world. I mean, that's pretty much the state of affairs today. So, to understand where history taking lies, let's take a little step back. Modern medicine, as we all know, is reductionist, and the reductionism comes in two flavors. One is it reduces the human body to a sum of its parts, which apparently can be managed independently. And so an ENT surgeon only looks at the ear, nose, and throat, or perhaps only the ear, or perhaps only the right ear, or whatever. And you can pretty much manage that and not need to know anything about the body or the patient's other problems, which is not true, but that's what the state of affairs is. The other reductionism is that it assumes that all people are the same and can be managed in the same way with guidelines and evidence. And for those who love the concept of evidence-based medicine, forget that that evidence has been gathered in a select group of people. Remember the inclusions and exclusions that you find in every randomized controlled trial, which means that the results do not apply to people in ordinary, regular life who don't really fit into those criteria. And that means that if you have 10 people with fever in the room, all of them will receive paracetamol irrespective of the etiology of fever. And if in 3 days the fever doesn't go down, they will receive antibiotics. If the doctor doesn't give it, the patient will take the antibiotic themselves because that's what they're now used to, irrespective of etiology. And so history taking in such situations has become virtually redundant as part of the practice of modern medicine. And this sets up the dichotomy and irony of modern medicine, that we emphasize history taking in our curriculum, in our everyday life, when we talk about patient care, but our management protocols and systems are designed to reduce the necessity and importance of history taking and patient interrogation. And it's not just us. Even the patient believes that it's often a waste of time and energy and would rather just have quick relief. And I mean, if you have a laborer who's coming into your clinic at 10 at night simply because they can't afford to lose a day's work, they are not interested in you sitting for 20 minutes and trying to figure out their life story. They just want a solution to their immediate problem at that point in time. But that's not just true of laborers. It's true of a lot of people who wonder why you're even asking all these questions and what is the ulterior motive. So it's both ways. Doctors do not have the time for calculation, and that's also pretty much true of patients as well. So how did, and I know that Dr. Ravi spoke about William Osler, and we've had all these other lectures earlier on modern medicine. And it's like the conquest of modern medicine. It has paralleled the improvement in health span and lifespan, most of which is because of improved sanitation, better nutrition, availability of clean water, elimination of infectious diseases with better vaccination and the use of antibiotics, and the associated improvement in child mortality. And so this is literally a 200 to 250 years old phenomenon. Prior to that, until the early 1800s, it didn't matter which part of the world you lived in. It didn't matter whether it was 1,000 years back, 2,000 years back, 500 years back, 10,000 years back. There was a 40 to 50% infant and child mortality rate. Most people didn't live beyond the age of 35 or 40, and the world population never crossed a billion because the births and deaths always balanced out each other, and there were times when the deaths were larger than births. Today, the reason we're at 8 billion is not really because everyone's become suddenly very fecund and is producing a lot of kids. It's just that the death rate has fallen so rapidly that we just have a lot of people living all the time. Now, one reason why, or probably the major reason why people didn't live long till the 1800s, and bear with me, I'm taking the longer route to get to history taking, was the lack of good treatment options for acute conditions, the complete lack of understanding of the human body, both anatomy and physiology, and the non existent knowledge of germs and other disease entities. I mean, it was either the miasma theory or, as we had for 2000 years, the humors and the dosha. So, the two systems that have dominated medicine have been the Greek humoral theory that basically then morphed into what we see as modern medicine, and the four humors. And at the same time, we had the dosha theory, which was the three humors or the three doshas. It's very likely that Ayurveda and ancient Greek medicine just cross-pollinated each other because there was movement between the countries. Again, that's not for today. Now, how do you classify a patient into a dosha or a humor? And the only way was to question and observe. And hence, in the past, the only medicine was personalized medicine. Today, that's made such a big deal of with this P4 medicine and the buzzwords, but this is what it used to be. Because in those days, when you didn't have much, the only way that a doctor or healer could actually get some action and get into doing something was to first understand the patient and their problems in detail. Spend as much time in interrogating the patient and friends and family as an examination, and then whatever possible treatment was available. And so while there was medicine even earlier, and you have Egyptian medicine, you have Aryan medicine, even prior to Ayurveda, the first recorded medical stories actually come around this time, between 600 to 400 BCE, starting with the Greek stories and the books. And so we have Of the Epidemics written either by Hippocrates or the people who were the Hippocratics, people living around or doctors living around those times. And you can read this here, that a description of the history in detail and then some amount of examination from which they made some kind of a diagnosis and then some treatment or whatever they had at that time. And you can see here that while that was an actual case, in the book on regimen in acute diseases, Hippocrates then writes about what you have to do when you see a patient, and that is essentially history taking and observation. And then Rufus of Ephesus around 100 CE actually wrote this up in detail, saying that you need to basically talk to the patient. Though he had his detractors as well. And at the same time, there were people who said, why? Just observe the patient, come to your conclusion and treat the patient. But the alternative was that if you didn't do that, you would obviously be making mistakes. And the same is true of the Sushruta Samhita, which is around 500 to 600 BCE, where the whole focus is on understanding what is wrong with the patient. And this is what you are told to do. That is, talk to the patient, talk to the relatives, understand the situation, all of which by the time the Charak Samhita came in, the 100 BCE to 100 CE, you see all of these things that need to be looked into to try and understand what is wrong with the patient. Eventually, in any case, the treatment was about bringing balance, involving diet and lifestyle modification, and hence so much of the focus was on the food and abstinence from food and types of food, abstinence from vices, exercise, yoga, purification treatments, massages, and herbal remedies, whether it was old Greek medicine, whether it was Ayurveda and traditional Indian medicine. When you didn't know what was really wrong with you, what you could do at that time was fit the patient into one of those doshas or humors and then figure out a way in which you could correct those imbalances and hope that the patient would improve. And really, the only thing that probably worked most of the times, and I'm sure some of the herbal remedies did really work, was the prevention and the lifestyle intervention. And think about it. This is how it continued with minor changes from the time of Hippocrates and Charak, Sushruta, and Dhanvantari to the late 1800s. For so 2000 years of recorded mankind history, that in some variation or the other, all we really had was people taking some history, looking at the patient, and then trying to come to a diagnosis, whatever that diagnosis was, and then treating in whichever way they could. It was only in the 1800s that things started changing. And if you go through this book, which is available on the PubMed site, you can actually go through the history of how modern medicine became what it is simply because of the way in which the diagnostic capabilities improved. And it starts with the fact that, dissection started around 13 to 1500, and you had those books, and then the nosology of disease by Sydenham, and then so on and so forth, right? What they don't talk about is Descartes, who made a huge difference. He was not a physician, but he was one of the most prominent philosophers of his time, somewhere in the 1650s to 1700, who said that all systems can be better understood by understanding their parts. And that is where the entire concept of how the parts form the whole came in. And this influenced the doctors, who also started saying that if we understand each organ of the body, then we may be able to understand the body as a whole. And that's where the entire reductionism came in, wherein we started assuming that we could just look at, multiple patients together, or look at a patient as a sum of all the organs and focus on the organs. And that eventually led to modern medicine. Interestingly, and this is very funny, right? Dogmatic literature on the art and science of history taking was and is still very limited. There is quite a bit on clinical examination, but not so much on history taking. So one of the first known texts on history taking is the Manual of Pathology. It's not pathology, but basically about diseases, written by the French physician Martinet, who again was very influential as part of the French school in advancing modern medicine at the time. And Dr. Osler also talks about him in some detail. So in 1829, then this was translated into English by Jones Quain, and you have this entire initial part which talks about how to take the history and why it is important, and then all the methods of examination of different parts of the body. There were no further books on the subject, but it was clear that history taking was just assumed to be so important that you didn't really have to talk about it. And that was quite funny. But if you look at the articles on the subject, and so this is a paper on apoplexy causing arterial dissections in the New England Journal of Medicine and Surgery from 1812, all of the initial part of the case is this detailed history that is written out. And clearly this is how patients were examined as well, even in 1812. Sir William Osler talked about bedside training. And while he's written so much, so many books, there is no specific treatise on history taking per se. Again, because it was just assumed that that is how it has to be. You have to talk to the patient, understand what's going on, then come to a diagnosis. Even in the early 1900s, this is when Richard Cabot, the famous physician from Harvard, was again putting all his cases together. And he was one of those who was instrumental in starting the case records of the MGH being published in the NEJM, though at that time this journal was the Boston Medical and Surgical Journal, and then it kind of morphed into the NEJM. You can see that the entire first page is entirely about the history. And everything is in so much detail, and then the examination, and then you pretty much discuss the case with the treatment and the diagnosis and the pathology, etc. Nothing much after that. So you have the 1829 book by Martinet, then you have the assumption that it's important, lots and lots of case reports. Sir William Osler talking about the bedside training of the physician and all of that. And then there were these two seminal books that made a difference and brought in a bit of structure into history taking. So we have Felix Duche and William Murphy's book, which was actually meant more for psychiatry, but then moved into mainstream medicine. And then the book by George Engel. He and his partner were in the University of Rochester in New York, New York State rather. And they actually created a curriculum where people would come in and they would teach them practically how to interview the patient. And these modules became very famous, and then they went countrywide, and the doctors kept writing out these books, which is what eventually they were able to say that history taking cannot be learned in theory. And this is what Dr. Osler used to say as well. You need to practice it on patients with a mentor to guide you. And perhaps that is why there isn't so much written about it, because that's pretty much, it was taken for granted that everybody kind of knew about it. A few other things about history taking. Record keeping was poor. Now, if you're taking the history of a patient, you need to record it somewhere. And while in the hospitals, there was some form of record keeping, in private practice, etc., it was very poor. You know, people would create some index cards, write out a few things, and these would be triggers for the memory of the physician, who would then remember everything because they were talking to the patients and the families for long periods of time over decades. And it would be in their minds until they became dementic or whatever. And so there wasn't a lot happening there. And so again, we do not have a lot of historical evidence of how history was being kept and taken, simply because of this poor record keeping and the use of our own memories for this. And this is where technology as part of our modern medicine makes a huge difference. Today, the push towards the electronic health record is changing that, because retrieval allows physicians to look at what was recorded earlier, to understand what is happening with the patient, and not have to, people don't fall through the cracks. At least that is the hope and the aim, that we will have all the information available so that people can peruse them, have them at a click of the keyboard or the mouse, and be able to look at everything that the patient has so that you don't make mistakes. Of course, that's the hope, but there are problems even with EHRs, but it's better than consigning things to memory. Patient interviews online. That is, I think, an evil that obviously COVID exacerbated, and now I think we're getting back to some balance. The first interview has to be in person. You cannot understand the nuances of the patient online. You could do follow-ups online if it's all about understanding treatment or talking to the patient to figure out what they're going to do next. But you cannot do the first interview online. So when you have an emergency and exigency, that happened with COVID, that's fine, but otherwise not. So funnily, Greek medicine eventually morphed into modern medicine, and the pathway that I showed and no longer exists separately. Ayurveda and Eastern traditional medicine, including Chinese and other forms of medicine, continue to parallel modern medicine, simply because they existed separately, and the conquest has been of Western medicine as modern medicine, right? And which then overpowered all other forms of traditional medicine. But today, even Ayurveda and other forms of traditional medicine cannot escape the same issues of mass production and reductionism. So today, you see that Ayurveda has been reduced to companies selling Ayurvedic medicines off the shelf, and patients believe that Ayurveda is nothing but the use of herbal remedies that they can ingest in the same way that they take so-called medicines of modern medicine, which are then called allopathic medicines. And the fact that the physician needs to sit with you, understand your problems, talk to you for about an hour. That only happens in Ayurvedic spas, but doesn't happen otherwise, simply because nobody has the time, including the patient. So, to summarize this short lecture, what is the history of history taking? Since the time humans developed language, people have been telling stories. And so, whenever a person was in trouble, somebody became a healer. And so, patient interrogation and history taking are as old as medicine and perhaps as old as humans themselves. From the time we developed skills and healers arose among our communities. What we do need to do as physicians, however, is given the way we lead our lives and the way patients lead lives and the way medicine today is to constantly remind ourselves that it boils down to talking to our patients, structured or unstructured. It doesn't really matter. Structured is better, but sometimes you don't have the opportunity to do that. But it is only after we talk to our patients, do the origin, duration, progress, past history, family history, social history, and all of that, that we get to learn and understand what is wrong with them so that we can eventually better treat them. I hope I've given some perspective on history taking and the concepts of medicine at large. Thank you so much for listening to me and have a great weekend. Take care.
Thank you so much for your lecture, sir. It was extremely interesting to see how history taking has evolved, and surprisingly how it's not. How, the standard format which we've been following here, which we're taught even today, was perfected quite early on and used by physicians since time of Osler and even before that. That was quite interesting to see.
Yeah, actually used 2000 years ago. So if you see the Greek books as well as Ayurveda and actually even Chinese medicine, which I didn't include, they've had structured formats of history taking since time immemorial. And as I said, it was so very important at the time simply because they had nothing else. I mean, if you understood the patient, you could offer some form of remedial treatment, whether it was placebo or whatever you did, including magic and rituals and all of that. But you could then do something if you knew what was wrong. And if you didn't, then there was no point. I mean, today, think about it, the laparoscopic surgeon whose only job is to remove gallbladders doesn't really believe that he needs to know whether the patient has had a hysterectomy in the past or not, or whether the patient has other problems or not, because that's the sole focus of that person who does laparoscopic cholecystectomies. And so where does history taking fit into all of that? It has to be the overall one person treating doctor who has referred to that surgeon. And unfortunately, that overall one person doctor who knows everything about that one patient no longer exists. So that concept of a family physician or an individual who would take care of you doesn't work at all.
We have one comment here by Lakshmi Vasudevan ma'am, who says that homeopathy is only history taking.
That's true. It is only history taking. And it works well because after the 1.5 hours of exhaustive history taking, everybody feels good and the placebo effect starts kicking in. And remember, homeopathy is part of the concept of modern medicine. It's not traditional medicine. It's just less than 200 years old.
I can see that Mr. Paresh Varthi has raised his hands. Do you have a question, sir?
Yeah, I have a comment to make and an observation. I enjoyed Bhavin's talk as usual. He has profound competence in delivering what was so simple in its subject, but making it so lucid and interesting. Congratulations, Bhavin.
Thanks, Paresh.
I have always enjoyed you talking, and was still an eye opener to most of the young doctors in the community that even today journals like NEJM or Lancet do mention in their case snippets or whatever that even today 70% of the job is history taking. You hit a diagnosis 70% of the times by merely history taking, and then leave the 30% with your examination, investigations, modern technology, so on and so forth. And increasingly, that is still not looked into by and large. So, thank you again. You really drove the point really well.
Thanks, Paresh.
Thank you, sir. We also have comments from Dr. Sushrit Soman, who's pointed out that Dr. Samuel Hahnemann, the founder of homeopathy, emphasized much on history from 1805 onwards. We also have a comment from Dr. Nilima Kadambi ma'am, who's pointed out that patience with patients is the key to good history taking and rapport building. Jumping to conclusions or depending on labs or diagnostics to treat patients is a medical legal case waiting to happen.
Yeah, I don't know. I think it cuts both ways. If you haven't done the requisite testing that society expects you to, that is also a medical legal case waiting to happen. And I think we don't have, I mean, there is, it's there's no judgment here because people follow whatever trends there are. And it's just getting more and more difficult sometimes to even convince patients. So let's say that you look at one of these ads that comes into your WhatsApp or email that offers you 46 tests for 999 rupees, and you get that testing done, which let's say has a vitamin D, a vitamin B12, and a serum PSA. And let's say your vitamin D is so-called low. To try and tell a patient that that's just a number and you don't necessarily need replacement, or that you shouldn't have done the PSA because if it's 4 now, you're in trouble because nobody knows what to do. It's a huge challenge. Patients believe that it's the technology that is what modern medicine is all about. And very few people understand that the reason we live long, healthy is really socio-political. It's about clean air, good food, water, sanitation, vaccinations, and some screening tools. It's really that. Modern medicine is like the top of the technology is the top of the pyramid. It just helps a few people and not entire populations. But it's both ways. The expectations from society by patients are also changing, and we need to understand what they are to stay a little relevant. And so just a long answer to a short, this thing that you can't escape all of these things. You just have to try and make a difference where you can. And the more you talk to patients and people, and not just patients, right? Sometimes it's just talking to people who are not sick to make them understand how to lead their lives and then try and help them out, starting with friends and family.
We have a few more comments. I'll just go through them in the order they've come. From Dr. Sunil Pandya sir, who says that the common excuse is that doctors have no time to take a detailed history. They're so busy and the patient load is so heavy, especially in public hospital OPDs. Dr. Kadambi also
it is true, right? I mean, if you are in a KEM OPD, let's say you're in ENT and you have to see 500 patients in that OPD, where is the time for a detailed history? So our curriculum, our method of teaching, it's all warped. And so you expect people to learn, but you don't give them the opportunity, except wherein you're in the wards. But in the wards, you see only a select group of patients who've been admitted. And not all patients need admission, yet have disease that requires treatment. So you're only taking a detailed history of those of that group of patients that require hospitalization, where you have a little extra time, but not the OPD patients. So what Dr. Pandya is saying is absolutely right. I mean, it's not even an excuse, it's reality. How do you manage that? That's why I think what Dr. Kadambi is also saying, time constraint, right? Yeah. Go ahead, Rahul. Sorry, I poached on your.
Yes, sir. So yeah, Dr. Kadambi echoed what Dr. Pandya had said. She said the time constraint is the commonest excuse to skip history taking, and teamwork with nurse practitioners and assistants helping the physicians may be the solution.
I agree.
There's also a comment by Dr. Manisha Srivastav, ma'am, who's thanked you and said that your talk has been excellent as usual. She thinks it brings home the point that it truly helps us and our patients if we're a people's person.
Absolutely.
One more comment by Dr. Kadambi, ma'am, who says that EHRs created with pre-consultation history taking and self-entry of past history may be helpful too.
Yes, that can help in reducing the time um, spent to take a lot of the history. And that's where, use of technology really helps in some of these things, and especially if you're not the first doctor, but the third doctor. And you do need to talk to the patient, but a lot of things are already done. So you can ask the patient what their problems are, but and at some point you can always intervene and say, look, we're not cutting you short, but I do have some more information, and is this correct or not? So let's just jump to the current problem. There are ways of managing that to save some time and yet get all the information that you want and create the rapport with the patient. All of that is very helpful if we can use technology correctly. We're still not there, but maybe in the next 5 to 10 years. Yeah.
Sir, and lastly, there's a question here from Gargi Goel, ma'am, who says that in a rural setup where the patient load is so much and the socioeconomic factors, which are hard to change, play a big role in the health status of such patients, how do you do a good job there?
I don't have an answer. It's a tough call. I mean, if you have so much time in the day. I mean, and some of them are just interested in instant relief. I mean, why do you think that clinics which have those charpoi sets, outside, where a patient after the day's labor feels weak, goes to the doctor who puts an IV and says, "Power ka dawai chada rahe hain," which is probably nothing but dextrosaline or whatever. They feel so energetic and good, and then they leave, and then they come back the next day, and some of them just do it once a week. कि bottle चढ़ाते हैं तो हमको अच्छा हो जाता है. So the point is, in many instances, especially when it's acute, subacute, a lot of people can't even afford a day off, nor do they have the time to spend with you to take it. You just want a medicine for that instantaneous problem. हमको बुखार है, हमारा बुखार बंद हो जाना चाहिए कल तक, नहीं तो I can't go to work, I lose a day's labor. We have to juggle all of that. So history taking is great, but it doesn't always work. It's not always required. Then you reserve it for the complex patients who are not getting better. And we also have to wisely triage based on, as Gargi said, time, socioeconomic status, where we are, the milieu that we are in. That's what makes a good physician. You have to adapt and adjust to the situation and do it accordingly.
So I think we'll take one last question from Dr. Jayant, sir, who said, what is the role of AI and machine learning in the future of history taking?
Oh, I love this. Imagine I'm sitting in front of, what would you say? A humanoid robot, or is it just an empty room with the AI listening? And then I am saying some stuff, and then the AI has some form of a bot which has been trained with like 10,000 questions, so they know what to do with follow-up questions. Will I be comfortable with that? Who knows? I mean, who knew that, 10 years ago we'd have this explosion of social media and a computer in our hand? Who knew 20 years ago, when I used to go to Fort to buy LPs, and my only source of music was the pirated stuff that the pilots would get on their airplanes, right, in the 80s and 90s, that today, I have Spotify. I have every damn song that I need to listen to. So I can't make predictions. I've learned that to try and predict is a fool's job. Perhaps we'll be more comfortable talking to humanoids, perhaps not. I don't know. I have no idea. I'm sorry. I mean, who knows where we will go.
Thank you so much, sir. So I think we'll conclude for the day. I'd like to point out that once again that we do have a lecture next Saturday. It'll be some more of our eminent teachers, and we hope to see everyone there. Good evening.
And I just like to add, I always like to have the last word, but Rahul, I just think this is an amazing initiative. I know I've not been attending, but now I took the opportunity to go through all the earlier lectures, all of today and yesterday. And it's amazing stuff. I mean, there's such a plethora of knowledge and advice and wise words. I'd like to thank all the speakers before me for taking the time out. It's not easy to do this. And Rahul and the team, great work. I mean, congrats, all the best. Take care.
Thank you so much, sir. Just end the meeting here. Good evening, good night.